Members, good morning. We have formed a quorum. I call the meeting to order now. Good morning.
Good
morning. I would like to welcome all participants. From the administration, we have officials from the Food and Health Bureau, Hospital Authority, and Labour and Welfare Bureau. I also would like to welcome all the deputations and individuals. Today we are going to discuss an important topic, and that is when the Joint Subcommittee is approaching the end of its life, we need to talk about how we should end, and that is our hospice care services. And it's a curse word to say that you die and you die not in peace. We want all the disease to pass away with the love and care of their family members. Some 90% or 40,000 people per year die in our hospitals. We have 360 hospice beds, according to the administration. And you can see the kind of shortfall that we are facing. And it's not just about providing services to the dying, but also support and public education, support to the patient or the family members. And we would like to see the peace of mind, support from family members, and properly arrange funeral services, and so on and so forth. So we'll be talking about the palliative care, and then we will open the floor for discussion. 18 deputations have come today. I don't want to give the administration the floor for an introduction because it's a simple paper. And also, please note that your speeches are not protected by the Legislative Council Powers and Privileges Ordinance, and that is to say you are responsible for what you say. And I'm sorry that I can only give each deputation 3 minutes. After the deputations have spoken, I'll ask for a response from the administration, and then there will be a Q&A session. The first deputation is Mr. Guan Kam, Society for the Promotion of Hospice Care. Well, the life expectancy of Hong Kong people is getting longer and longer, and that is the stage when one is approaching death becomes longer and longer. In the past, people might suffer some disease and the death will come quickly. And now we are getting a longer end stage, so to speak, so there's a bigger demand for hospice care. Well, actually, in terms of the stage of development, we are in a very advanced stage. But it's mainly provided to the cancer patients. But since dying is something that we all face, the development of hospice services should be extended to all. Everyone should have the chance and the right to have access to hospice services. But of course, we need the community to invest, to expand resources on such services. If we are to expand the services beyond cancer patients, we have to take into account the need to extend or develop the community services because of the aging population and the needs. Because we cannot ask all our elderly people to go to a residential home or to a hospital. If we want to promote community care, then we need to do a few things to tie in. For example, health care services should be provided in different settings, not just in a hospital, but also in the community, in their residential homes. And then when they are injured, when they are sick, they should be able to go to hospital, but at the very end, shouldn't they also be allowed to die in the community? Because ultimately, the patient will have to go back to hospital, and then that's where the problem lies, the lack of sufficient healthcare personnel and services. And we need to train the healthcare personnel, including doctors, nurses, social workers, psychologists, and other workers. We need to provide proper training in terms of medical knowledge and other skills. And we need to do public education. Otherwise, people will not understand that this is what happens when one approaches the end of one's life. And we need to do something in community to serve them. Next, we have Mr. Leung Chi-tun from Sin Kung Hui Holy Carpenter Church District Elderly Community Center. On hospice services, I want to make 2 points. It's not that we don't have such services in Hong Kong. Public hospitals are providing such services, but there are 2 problems. I'm a social worker. I'm a frontline worker, and I'm dedicated to the counseling and care for patients, hospice patients. Let me first of all talk about hospital settings. Yes, they have hospice centers, but there are only a few beds, 10 odd beds. If you are admitted, you get good services, but most will not be admitted, and they will be in they will stay in a general ward, and you are cared like any other ordinary patients, whether in terms of attitude or the treatment you get is the same, whether you are a dying patient or not. and the dying patient faces pressures, psychological and physical pressure. I understand that it's not easy to just ask for more beds to be provided, more hospice beds. But we do see that an arrangement is possible. For example, we should arrange for the patient to go home as far as possible, and then we will provide healthcare services, care, and support for family members, so the patient can stay at home. Well, very often the patient or the family members would like to have the patient staying at home, but they do not have the necessary medical equipment or expertise and skills to care for the patient, and therefore they are deterred. And if you want to wait for a place in a residential home, you need to queue up and wait for your turn. And if you want to go to a private residential home, it's costly. So when these options are ruled out, they have no choice but to stay in hospital. So the community care that we need to develop is to provide multiple choices. For example, their own homes, and support to the family members should be given so that they can be, so that the patient can be there on a prolonged basis. And the care provided to the patient must be around the clock, because very often the situation may deteriorate to such an extent that the patient has to be sent back to hospital. Your time is up. Next, we have Ms. Dr. Chen Kin-sung from Hong Kong Society of Palliative Medicine. We have a aging population. More and more people need hospice services. My society wants the government to come up with a comprehensive policy covering 6 points. First of all, end-stage patient is not just facing terminal diseases. Taking care of terminal patients now is restricted to the chronic diseases. We propose that we should use palliative services instead of hospice services. For those suffering from serious illnesses, they face physical pain and emotional problems. Palliative medicine can be applied at an earlier stage and to tie in with other healthcare services. Palliative services is a term that can more accurately reflect the need of the patient, as in line with international trend. A comprehensive palliative medicine should be given sufficient importance. The administration should delineate the roles and the relationship with other services, social services and medical services. And also the administration should look into the shouldering of or the sharing of responsibility between the public and private sector. And there should be a life and death education for the public. People should start to think about death, life and death early in life. And we should also understand the choices of maintaining the patient, and also the choices and what they mean. The administration should also incorporate this aspect in the education programs for doctors and allied healthcare professionals, in order to give the patient the right to make a choice. The administration should pass legislation to give statutory backing to the people's instruction when they can no longer able to make a choice. And because of coronary court's rules, all deaths in residential homes for the elderly have to be reported. And there should be progressive training enhancement for the various healthcare workers in the public and private sector. With more people in need of palliative medicine, and since other specialties are also involved, there should be proper cooperation between different specialties. For example, the training for healthcare workers, and also devising the palliative programs for patients of different category. Ms. LEE Siu-po, I won't speak at this moment.
Ms. LEE Siu-ying. I personally am a social worker, have been working for more than 20 years. When I provide community services, I find that many people really, when they're seriously sick, they want to pass away peacefully at home. But if an elderly person passes away at home, we would be placed under heavy responsibility. People may ask us why we should leave them at home. Doctors may say they better rest at home, but doctors wouldn't make it clear that they may pass away in the end. So sometimes we're not sure what we should do. Whether we should, even when the ambulance arrives, when they reject going to the hospital, what we should do. So, as we said last time, we, we share with other social workers that for richer elderly people who have access to information, and actually, they don't know about the palliative care services available, and we want to know how we can help young elderly people before they die. Actually, elderly people should actually be accompanied by people they trust. But for many organizations, so far, not many organizations or community organizations can actually tell them about palliative care services. And how much knowledge and skills do social workers have in actually providing or helping these people or their families find funeral services? Sometimes other people say, oh, they only trust you, one particular social worker. And even other, some families may ask me for a refund after they, are dissatisfied with the funeral services that they get. So there needs to be training for social workers and training for social workers to deal with these dying people. Just we talk about 24-hour service. Sometimes now home care teams only provide services till 8 p.m. So how are we going to provide services beyond that? So there could be special services and funding dedicated to that purpose. If you want to hire specialists, for example, or special carers, they may charge tens of dollars an hour. So how are we going to provide 24-hour service for dying patients? Okay, next one is Lam Ning from the Forthright Caucus. Well, we're now talking about hospice cares in Hong Kong, an issue about how to die well. Often we've tried our whole life's effort to see how to live a good life, but we rarely think about how to die well. In Hong Kong, it's not easy to die well indeed. Death is not just something that happens at an instant. It is a process. So hospice care involves broad areas. But Hong Kong, there isn't a complete hospice care policy. The government's paper submitted today focuses on palliative care services, but palliative care service is inadequate to make someone who's dying die well. Hospice involves how the whole society looks at death. That needs continuous life and death education. When a patient's situation deteriorates, to the extent that he faces a lot of pain, of course, then is where palliative care is needed. But at the same time, his family members need emotional counseling. For example, a single dying person, maybe an elderly person or mentally retarded person, are there services and policies to help them die? And then also with the funeral services provided for that person? We don't have a complete policy. So in Hong Kong, if you want to die well, it's difficult. Looking at policies or legislations here, you have to overcome 5 hurdles before you can die at home. Because if you can't find a doctor to sign a death certificate, then the person will be classified as dying of a natural death if he passes away at home. And only if a death is certified to be dying peaceful death can there be arrangement for the death certificate. And then there could be a chance for autopsy afterwards. And the process of dying is so complicated, and sometimes family members don't want to see a body be performed autopsy, so therefore they don't want to maybe send them away. But according to government guidelines, elderly patients can predetermine medical guidelines or medical procedures, but that only apply to public hospitals. Ambulance services are exempted from the guideline for medical procedures or predetermined guidelines. So even if a patient has predetermined medical procedures on the ambulance, the patient may be subject to emergency treatment. So why should a dying person be held responsible for, the last or the surgery or the treatment to be given to him at the last minutes of his life? So the government need to consider setting out a comprehensive hospice policy so people can live and die well. Next one. Christine Fang. Good morning. I'm not speaking on behalf of the Council of Social Service today. I've left the council, but I'm sharing here as a person and as someone who's seen, how our parents are getting old, and yet there are people who don't die well. I provided a written submission as well, so I hope that members and the administration can look at it. When I was at the steering committee on the population policy yesterday, I also submitted the same submission. I think, first of all, we need to have a good hospice care policy in response to the society's needs. We are in an aging society, so inevitably more people will die. But it's not just a change in numbers. I think for elderly people in the future, they do have expectations for arrangements for their death in the future. You can see the palliative care services now focus on cancer patients. How about people who die of chronic diseases, respiratory diseases or dementia or all sorts of diabetes? In fact, the existing palliative care services actually do not treat all these diseases as priorities. They focus more on cancer. And hospitals is where lives are saved. There are a lot of procedures that patients have to go through. But for many people who just want to die peacefully, they don't want to go through a lot of procedures, and currently there aren't many choices for them. In other countries, in response to the aging phenomenon, actually overseas, they have a comprehensive, cross-departmental hospice policy. In the UK, for example, they've got 4 dying well targets. First is to provide dying patients a dignified, appropriate, high-quality pre-death, after-death support services. And in the UK, they also try to help control the pain and torture suffered by dying patients. And thirdly, they want to give the patients a choice of dying in a familiar environment in the company of family members and friends. So those 4 dying well targets, you can see it later on. Indeed, compared with these targets, the quality of dying in Hong Kong is really bad. And hospice care should cover not just health and welfare, but other areas. As I said, we should popularize life and death education in the community and also in schools. And also we need to have integration between health and medical services, and also we need to enhance support for dying patients. And give me 1 more minute, please. I think for dying at home, we need to actually incorporate hospice support into our home support services. And to provide sustainable services in the community, we need to incorporate hospice services into residential homes for the elderly. So these homes provide hospice care as well. And also, community care services also have a role to play in promoting life and death education and also providing people-centered services. For details, I think other organizations may pick them up. Next is Salvation Army's Ms. Irene Lam Puyu. Good morning. I come from an organization that provides community care services and residential homes for elderly people. Looking at current figures, that is, there are 70,000 elderly people who live in homes for the elderly. 90% of them actually are having chronic diseases. And in the past, we introduced a pilot scheme in which elderly people could die in our residential homes. Based on our experiences, we found that we can see the situation of people dying, in our homes. And we've got 2 targets for future policies. First, I think when an elderly person reaches a stage where their physical condition is so bad, they do want to reduce the chances of having to go back and forth between hospitals and home. And they don't want to actually give too much burden on the families. And so we need to reduce the pressure, the burden they face. And we also need to increase the choices available to these elderly people, choices about how to prepare for their funerals and death. I think at a certain stage, elderly people should have the choice of how to die. So we have 5 proposals under the 2 targets. After trial, we, in our provision of hospice services, we find that it's possible, it's feasible, with conditions attached to provide hospice services at elderly homes. Under a policy of long-term care for elderly people in our homes, we hope that our elderly patients can have access to a lot of care and also hospice services. As Christine Fong just mentioned, if we are to provide hospice care at elderly homes, so there needs to be support and extra resources for it. And these provision of hospice services should be actually included as the regular services provided for across elderly homes. Of course, the carers at homes need to be given additional training to ensure they are capable of providing the suitable services. So it's not just a matter of people, but also training and resources, particularly resources for providing hospice care. And fourthly, we need to have the support and cooperation of medical sector and also government departments. And another proposal is that there needs to be more support for manpower in residential homes and training of staff in elderly homes. It's a continuous training that we're talking about. And lastly, public education, because this is really something about life and death, and it's an important lesson for everyone.
Next, we have Mr. Le Ho Yun from Labour Party. Well, hospice services are about the dying well, and the HA is an important organization in our system. But there are now some inadequacies. Some 90% of patients die in a hospital, but we only got very few hospice beds. When a patient has applied for palliative service or hospice service, are they going to get the services? Have there been statistics? It's not really nice to ask to let the patient die in an ordinary ward. So things should be improved. We want to die with dignity. And they should be able to have a choice as regards where they should stay when they die. And we also know that we need to improve palliative medicine. I know that the workload for medical, social workers, and other frontline workers are very busy. Some have to work very late up to late at night. So the government should review the manpower, as other speakers have said. Do we have a hospice policy involving both the healthcare and the hospice service sector and social service? Can we make sure that the three can complement each other? And we also need to promote public education on life and death. It's not just needed by the elderly. All people need it, especially even young people need it, and the disabled also need it. We need to face up to this problem with an aging population, even for the disabled. And for the bereaved, when they face grief, then the social welfare sector will have to face a greater burden. Has the government got a comprehensive policy in the provision of emotional relief services? There are many services, but we need to have a coordinated approach to make sure that they all are in place. Ms. Yung Lai from Hong Kong Association of Gerontology. We all know that the aging population is aging. In 2012, the census figures tells us that is deteriorating, it's getting more and more serious. And in 2041, we are going to have 37.3% of people belonging to the elderly brackets. We must not ignore the chronic diseases suffered by the elderly. Although the SWD has long-term services, but very little is done on hospice services. My association, from 2007 to 2009, and in recent 3 years, we carried studies on hospice services, assisted by NICE Canada, and another organization. We have conducted surveys. We have also conducted another one with another charitable organization. So from the findings, we know that many elderly people would like to get hospice services, and when they pass away, they want to be properly taken care of. For those working in residential homes for the elderly, they are not concerned about having to take charge of such patients. It's just that they don't have the necessary manpower, healthcare support, and also the legal services that are needed. The government should look at the need to provide manpower. Our association has been doing assessment, and we have been assessing the residential homes based on certain criteria, including hospice service. But most residential homes are just beginning to provide it because of the conditions that they are in. And very often, when a patient is dying, his physical conditions are poor, and they don't. And very often, there's no advanced medical instructions. And so the patient may have to go to and from hospital very often. And some are suffering from degenerative disease and is already terminal. And the hospital may not be able to offer much help. But sometimes intubation is required just to maintain life, and the patient suffers. So what about the quality of life at the end of his life? My association suggests that the administration should devise a long-term hospice service policy, and there should be proper review of the laws, and the SWD should take into account hospice service in assessing residential homes. And we hope that hospice services should be covered in the assessment. Next, we have Mr. Sam Chi-wing from St. James Settlement. Thank you, Chairman. You said at the very outset that this subcommittee, joint subcommittee, would like to uphold the rights of the elderly. When we talk about services, we are talking about other people. If you spend 10 seconds about yourself, what would you like when you are going to die? Then the answer will be much clearer. We have been engaging in St. James in life and death education for the past 10 years. We encourage elderly people to plan well for their death and what they would like to get done after they die. But there are a few problems. Some elderly people would like to donate their organs or their belongings. Well, this is a gesture of love. But when their family members object, their wish is overturned very lightly. Some elderly people will tell us that they would like to do this or do that after they die, but when they really died, their family members would just do what they want. And sometimes when you ask the family what they would like to do for the patients, do they always respect the views and the wishes of the patients? We all want to educate them to do proper planning beforehand. But what's its use if their wishes are not respected? Very often they feel helpless. What they do would come to nothing. So is that not a question of human rights? There should be some systemic safeguards. We want these old people to die well, and they should have a peace of mind before they die. Otherwise, their physical and emotional well-being will be affected because they will never know what would happen once they die. Ms. Lo Yun-ching. Thank you, Chairman. I'm a special education worker. In my work, I have worked with many parents on disabled students. I have witnessed the passing of many disabled students with disabilities. Hospice services is not just talk about the moment that the student with a disability passes away. It may be a protracted process. We are concerned that hospice care services should also look at the well-being of carers, homes, families, and not just the person himself. Many people with disabilities, if they have cognitive power, know that they would their death would come any time, and the parents are also aware of this. So it's important to get parents psychologically prepared for residential home carers. They also be getting support so that they can cope with the passing of a young life, so that they can remain strong, and then they can take up the job of caring for those who are still living. And we need to provide a minimum protection of the quality of life if the patient chooses to remain at home. We talk about support or allowance for the carer, but this has not yet implemented. Some of the parents may want to take their child to fulfill their last wishes, or perhaps to visit a place, but transportation is a problem. And when the child passes away, they need to get counseling and emotional support to take care of the grief, so that they can make a new start later. We rely on CCF and other organizations to provide the services. And children with disability may find it difficult to express themselves when they have pain, or when they want to express their views. And also there are often children who may need volunteers or workers in homes to take care of their deaf. And they're just like the family members of the child. The SWD should provide the service, should help them as if the child is a family member. And they don't even get, sometimes they don't get proper funeral services. We don't know when the body will be cremated, for example. And these are people, and we should respect them. And there should be proper training, proper power provision for workers. And the important thing is that people's dignity should not be lost just because they have disabilities. Dr. Amy Chow from the University of Hong Kong, an academic in Taiwan, talk about 5 things in hospice care services. It's not just physical need. We have to take care of emotional and other needs. And then the process should be comprehensive from the very beginning, when the person knows that he's going to die, to the very end. Hospice care services should cover the entire period, and the family members should also be served. It's not just about services to the disease, and this should be interdisciplinary in nature, and then it should be community-wide. The important thing is that they are not asking for community resources, but rather the community should be mobilized, and everyone should chip in. And then I want to make 3 more points. Other deputations have said that family members should be the service targets. I have been involved in many emotional support services for families. Many families feel a sense of guilt because they did not take good care of the disease, and it's a long-term torment. If better services can be provided to the family members, and so that when we do a good job, or when the time comes when the inevitable happens. We are facing a lot of challenges. We have a bigger elderly population. There will be more deaths, and the average household size now is 2.9. So the elder may just have an elderly spouse and adult children, And if he's suffering from chronic disease, he will need more support from the community to take care of his conditions. And 1 in 8 households are elderly households, and that is to say they don't have care and support from other adult family members. And we have very few babies, 2.6 in 2006. In 2012, it's 1.1. So we can no longer depend on children to take care of us. So the government should provide community service in the long term. And let's look at the global situation. In 2010, the intelligence unit of the economies conducted a survey, and in terms of quality of death, Hong Kong ranked the 20th. Our palliative medicine is number 8, but why our overall ranking so low? It's because we don't have a government-led hospice care policy. So I propose the government devise one. Next, we have Siu-po Center on Aging, the University of Hong Kong, Dr. N.T. Ho.
It's a big issue, aging. Actually, Hong Kong is actually ranked high in the world, in terms of the number of elderly people living in residential homes. Actually, we've got hundreds of thousands of elderly people in residential homes. So end-of-life care is very important. But in overseas, often residential homes also provide life care for elderly people. In 2011, there was a large survey that covered 1,600 elderly people living in residential homes. 90% of them thought that they needed more care. And more than 40% felt that they could die in residential homes. So there is a big demand for actually palliative care for elderly people in residential homes. Many of these elderly patients or residents have chronic illnesses. When they have a fever, the first thing that happens to him is that they will be sent to hospital. Actually, nowadays, elderly people we have a revolving door syndrome among elderly people here because they have such a high frequency of going back and forth between hospitals and homes. And we know that medical professionals have a heart to provide palliative care. And at Queen Mary Hospital, Tuen Mun, or Tai Po hospitals, they have a lot of collaborations with residential homes, and they found that actually residential homes can provide end-of-life care instead, so that the elderly people can live a high-quality life at the end of their lives. So how can we seize the opportunity, and how can we make further improvements? We can actually we can actually try to integrate more services together. And as long as the government takes the lead, I'm sure that we can actually have provide more interdisciplinary work so that various groups and services providers can actually put together their resources, and better quality services can be provided to the elderly people. Life and death education is important, whether within a community or among professionals, nurses, and social workers. It's very important. Often, people ask why doctors are not aware of how to care for the elderly people because they were never taught about life and death education. So that's a kind of failure indeed. We can actually enable people to learn. And frontline social workers should be psychologically prepared to provide, death-related services for elderly people. We hope that more than 200,000 elderly people now living in residential homes should live a dignified life and die peacefully. Okay, the last one is Mr. Lee Chi-yong from the Association of Parents of the Severely Mentally Handicapped. To parents, it's a curse and it's a big pain to have to see their children die. But we do want to see that, should their children die, these parents can feel comforted, by quality services. So we should ensure that no matter who it is, when they die, when they experience death, they wouldn't feel as lonely or painful. So during the process of dying, the mentally handicapped people experience the same feelings. It's just that they may not be able to express their feelings in words. So Parents Association feel that life and death education is very important and it should be promoted in our community. And hospice care now is so inadequate. For most people, they live the final moments of their life in a cold, hospital environment. And even some family members may not have the chance to see their family members before their death. We always want to care for our, mentally handicapped children, and not to mention, parents of mentally handicapped would want to see their children even in their last moments of life. So our association is very concerned whether there could be better services provided for them, and also funeral services as well. For example, to get columbarium services. If parents are better prepared, then they can actually try to get the social welfare department to help. And we do hope that the government can come up with actually proper hospice care so that everyone can have a life of dignity and die with dignity as well. Personally, my daughter is a seriously mentally handicapped person, and she also has genetical diseases, so she has every chance of dying. In 2008, she faced the same crisis. I wasn't prepared, and I didn't know that she was about to die until the doctor came for a checkup. Then I knew that she was actually vulnerable to dying at any moment. The doctor told me to consider, to be prepared that she could have her life prolonged by machines. And the doctor asked me to make a choice, as to reducing her pain in the future. I almost collapsed at a moment when I was prepared to collect her belongings and to take them to the hospital to accompany her. I received a text message saying that about the earthquake in Wenchuan, China. When I saw the Chinese text, I collapsed. I thought the text was referring to my daughter. When she faced the possibility of death the second time in 2008, just 2 minutes before that, the doctor had not told me that she was at a critical moment, and yet 2 minutes later, the doctor said that her heart could stop beating any time. I was, close to passing out, but I insisted on seeing her at the hospital. Right now, every time she's still alive, but every time she went to hospital, I dare not leave her for a minute because I don't know when she would die in hospital bed. So I hope that when a doctor told a family member when someone was about to die, the doctor should also let me know of hospice care so that we can have some sort of emotional support. We were actually not prepared to face the death of our children. And it's too great a news for us to bear. When the doctor suddenly tells you that you'll die, or your son or daughter could die at any moment. Thank you, Mr. Lee Chi-yong. I think from the sharings given so far, we know how Hong Kong people, could experience, when it comes to, the issue of dying. There is the hospice service or hospice care policy in Hong Kong. If there is a policy that allows us to make choices, there aren't enough support available. So there could be, the need for amendments to the law. And if there are no amendments to existing law, then the amendments would be actually inadequate. So we need to have more community care services as well. Maybe let's ask the administration to respond to what we've heard and see what we can expect for the future. Ms. Lee, please. Thank you, Deputations, for attending today's meeting and your valuable views, your forward-thinking proposals. We agree that when we approach the end of our lives, it's a process. Dying is a process. Even with advancement in medical technology, we live longer, and the process inevitably will also be prolonged. Therefore, the hospital authority, apart from trying to save lives, it has developed a cross-disciplines team to enhance its medical services. You just mentioned the urgent need for palliative care services. Now we have 360 palliative care beds in the public sector. Of course, I know that people die would treasure the moments spent with their family members. So therefore, we know that these people may want to be moved back to their homes. So for home care, we know that family members may not be well equipped or have the knowledge to look after dying patients. Therefore, we've arranged for teams to pay visits to these families so that patients who have been discharged from hospitals can still be given medical care and services when they're back home. For details, I can ask my colleague from HA to give you the information. I've heard also from deputations that elderly people should be given choices, on, for example, medical procedures that I want to see followed. I think depending on the seriousness of the case, the doctors concerned actually have guidelines on, can tell the patients what choices they have. I've heard that in the past, HA's palliative care services tend to focus on cancer. I know that there are more and more people dying, suffering from chronic diseases lately. So HA has expanded such care to other long-term patients or patients suffering from deteriorations of their bodily organs. But there is a limit to our manpower and resources. We've also actually been concerned about support for elderly patients' family members. So we've got bereavement services on offer, and we've collaborated with community services to train social workers to help them make good use of community services so that patients and their families can be supported. But for concrete services, may I ask Dr. Dai to supplement? Yeah, I think let's focus today on let's just not recite what's been said today. I know the administration keeps saying that they've got every services available, but then the provision of services is disproportionate to the need. And there are lots of gaps in services. I don't want... you can keep talking about existing services for 2 hours. So let's look forward. Let's see, having heard from the deputations, let's not just keep repeating what you've been doing. Dr. Dai, can you just say, just as Ms. Lee said, the HA will increase its palliative care services. So can you tell us what your future plans are? For example, how many more palliative care beds would you increase in the coming years? How about home visits? Will there be more teams paying home visits? Can you provide us with those information? Chairman, I was about to say that of the 360 palliative care beds, we constantly review the number of beds and our standards of services. Lately, we've looked at our services again. Internationally, palliative care services or beds actually, comparison with overseas figures, our figure is not low. Compared with the UK, it has a ratio of 39 beds to 1 million people. So comparatively speaking, the ratio in Hong Kong is not low. But you need to understand that palliative care is not just confined to the hospital setting. As I said earlier, generally speaking, we also provide a series of services including outpatient, daycare, treatment, and home care, outreach home care. Particularly for outreach home care, that's very important for patients. We do hope that unless someone really needs, hospitalized services, we will try to get the patients back home so they can spend the remaining days of their lives at home. We do provide a lot of outreach home care. In 2013, we've got more than 25,000 home care visits made by our outreach nurses and palliative care nurses. So that's an important area of our work. On the other hand, we also understand that patients and their family members may need counseling, particularly bereavement counseling for family members. 2 years ago, we have enhanced our work in that we would try to test whether family members are in deep grief, and we try to intervene at an early stage to provide them with counseling until the patient involved has passed away, or until after some time after his death. So looking to the future, we do hope that we know that it's important to provide palliative care services. We have been providing such care for non-cancer patients. We know that there is still a gap in that kind of service, and in our annual plan, we would provide proposals to increase palliative care services. Our initial idea is that for home care visits, we do need to enhance the home care services, and that's our plan for this year. For HA, of course, we work according to our priorities, and at this stage, we're still considering, how to enhance our services. Hopefully, we can get more resources from the government. So we try to increase our services on an annual basis. But we do know about the need, and we will, in our annual plans, try to make increments. So you haven't got any concrete plans for, how many more teams or visits should be made? No, we don't have the concrete figures yet. Okay, how about Health and Welfare Bureau, Social Welfare Department, Mrs. Chen? Thank you, Deputations. We can see today that apart from medical services and hospital care services at the community level in the past 2 years, we've done quite a lot. Let me spend some time on talking about our services so far. At the community level, quite a number of deputations have said that support for family members is important.
We hope that more manpower can be provided so that we can do counseling. As for training for carers, we have already devoted more resources to do this. Some deputations would like us to look at life and death education. We can certainly do more. In the homes, in residential homes, we have received some suggestions from their written submissions. It said that elderly people would like to pass away in a familiar environment. So we also advocate continuous care in residential care for the elderly. We have started to carry out a transformation program since 2005, 2006, so that we can provide places that can provide continuous care. And since 2013, 2014, 14,000 in the subvented sector have been turned into continuous care places. And this concept has also been introduced to our nursing homes. And some deputations suggest that there should be a collaboration between the hospice care and continuous care. Some residential homes are already doing this through some pilot schemes. This year, we have secured resources to do hospice care in the 5 new contract homes to be commissioned in 2015-2016. We want to provide systemic care, hospice care for the elderly and also for the family members, emotional counseling and support. I think I should pause here, Chairman. How about the new service? Can we be given some information? Or is it in some part of your program? The 5 new contract homes. In our paper, paragraph 14, we briefly mentioned this. In 2015, 2016, 2017, these 5 homes will be commissioned. They are contract homes, residential homes. If you want to know their names, I would ask my colleague to supplement. I'm interested in knowing the resources that you are going to provide and the service scope. Ms. Lee, Ms. Cecilia Lee, we have 2 contract homes for which tendering has been completed. In the tendering document, we have put in a requirement that they have to provide hospice care, and the bidder will have to tell us what they are going to do. We expect them to have trained personnel and some clinical psychological services, and there should be a care room, special room, so as to provide a home-like environment for the residents and their family members. We're still vetting the tender document. When the contractor is identified, the successful bidder will have to liaise with the hospital in the district to come up with some further collaborative arrangement. So you request the service provider to do it, but this is an outsourced tendering exercise. You have higher and higher requirements, and whether you are going to provide more resources, it depends. We provide more resources. We do provide more resources, Chairman. How much? On hospice care. Of course, it's a contract for the overall service. We'll provide a contract sum. And if you compare this with other contract homes, we have provided for part-time doctor, part-time nurse, and part-time care workers. Maybe it's better you tell us in a paper what's the fraction involved in the part-time of doctor and nurse and workers, and how many hospice care cases can be handled, and then we can see if the resources tally with the service scope. Chairman, we have learned from the experience of some residential homes which have completed pilot schemes. We'll give the residential home a lump sum so that it can be flexibly deployed. Instead of specifying, it should be 0.2 doctor. That is, the part-time doctor should be 0.2 of a full-time doctor. we think it's better to give the contractor flexibility. Yes, you provide a lump sum. Whether how they utilize the resources is for the contractor. They would do it flexibly. But you have increased the resources to the contract homes in terms of hospice care. You must have a formula, and of course, in calculating the additional resources, you must have in mind the amount of manpower involved. I can give you the entire sum. But in other words, can you tell us the amount of increase in resources? If we compare this with a normal residential homes with the same number of places, we can make a comparison. Okay, so you can see that the difference in the unit cost reflects the additional resources. You can put it like that. So members may like to judge how much more is provided. The deputations have spoken in one voice, almost in one voice, that the government should have a hospice care policy. We have a Food and Health Bureau, and we have a Labor and Welfare Bureau. Who is responsible for hospice care policy? Ms. Lee? Chairman. We agree with the points made by the deputations that we need to explore the overall direction to take. We started the exploration process with the hospital authority to see how the healthcare part can be better linked up with the residential home services and the community. We have learned from the deputations' submissions that at present or all along, Hong Kong has been adopting the traditional approach in dealing with the elderly people passing away. Very often, elderly people would live in a residential home, and they have to pay visits to hospital frequently, and it's not good quality of life. And as some deputations have said, very often the elderly people would like to receive continuous care in a residential home. We have talked to some geriatric doctor to see how we can better unite hospital service and residential home service. And then we need to review the legal environment to facilitate the provision of continuous care in a residential care home or in the elderly's own homes. And so anyway, we need to look at interdisciplinary issues, and we need to involve, we need to cooperate with other bureaus. We have been talking about this with the HA, but we do see that that we should move ahead together. I hope we can hear some specifics very soon. I don't understand why so little attention and so little resource has been put into this topic, but death, that is death, and everyone has to face it. So 5 minutes for each member. Mr. Poon Siu-ping. I'd like to thank the deputations for coming to let us know your views. Some of the questions have been asked by the chairman. I want to clarify some of the views of the deputations. You have criticized the lack of a comprehensive hospice care policy. Of course, it's the job of the Labor and Welfare Bureau, the Food and Health Bureau, and other departments. And the chairman asked a question about which is the lead bureau, and the reply is that they have some internal discussion. Dr. Chow mentions that Hong Kong ranks at the 20th worldwide in terms of quality of death. How can we improve our quality of death, and what are the issues that we need to tackle? Are the provision of resources the major obstacle in overcoming the challenges? Dr. Chow? Well, actually, my analysis is based on the report. Hong Kong scores high points for hospice care. We rank number 8. The healthcare workers are doing a good job, but we get a lower score. It's about the comprehensive protection for the elderly, healthcare and social security. And we also lose marks for the lack of a comprehensive hospice care policy, because this is a multidisciplinary issue, and if there's no coordination, then we get low marks. We rank number 31, the lowest 25th percentile, that is, in respect of that aspect. It was done in 2010. We don't have anything newer than that. For the very first time, they conducted a survey into the quality of death in 2010. Deputy Chairman, sorry. I just want to understand a few things here. I've heard from the Food and Health Bureau, Ms. Lee, that you want to move ahead, you want to do it more comprehensively. I hope you can move another step forward. The departments are important. For example, Food and FEHD is responsible for the provision of columbarium niches. And also, some of the services are provided by religious organizations. Some are doing well, and some are doing rather not well. Some are too commercialized. So there's a basis for the Food and Health Bureau to take the lead, because the department, FEHD, under you, is doing some important things on this front.
I do hope that you can invite them along. Of course, they will just look at how to manage things, but I think you need to invite them anyway. And secondly, I hope that you can give us a picture of how you're going to deal with it. Will you appoint a committee comprising people from the academic sector or service sector, or would you hire organizations to compile a report to you as the basis for discussion? So how are you going to approach it? And lastly, as we've heard, even hospital doctors or medical social workers try to get the family members to sign authorization papers. But even sometimes, there are cases where, ambulance services are separate, are run separately from the medical services provided in hospitals. So should we raise the issue with the which bureau should we actually raise this issue with? Ms. Lee. Thank you, Deputy Chairman. As we said, we have actually explored long-term policies with HA, and we need to first of all identify the scope of our review. Initially, we think that we may carry out some studies first to get to know about overseas experience, and also to look into current legislations, whether there are any inadequacies here. So we want to identify areas that need to be overcome, hurdles that need to be overcome first. and try to provide continuous palliative care services. So we do a study first, and then we'll see, and depending on the conclusions of our study, we'll see what departments need to be involved. But that chairman, you said that funeral services and columbarium would need to be taken account of as well. As for emergency services, understand that the HA, in order to give people clearer guidelines on when sort of respiratory or emergency treatment should be given. I think I can ask Dr. Dai to supplement. I think in HA, in 1998, on the CR services, actually, we provided some guidelines for hospitals. That is, for some patients, for whom CPR, we are talking about chronically ill patients and terminally ill patients. For these patients, if the doctor thinks that CPR would not be of much use, that it will only prolong their lives, then the doctor would be entitled to discuss with the family members, whether CPR should be administered when the need arises. Can you be short, please? And in 2014, we've issued a new directive for chronically ill patients, for example, patients with terminal stage cancer. Just last month, we issued a new guideline. But the guideline is only applicable to hospitals governed by HA. We've also shown the Fire Services Department our guideline, and the department decided that so far it would not follow the guideline. That is, say, if the patient has the form, and if it's on the ambulance may not necessarily follow the guideline concerned. So recently you've discussed the issue, right? And that's the outcome of your discussion, right? Yes. But that's a guideline for HA alone. So the patient takes the form to our hospitals for emergency care, and if the doctor sees that there are no other problems, then he would accept the form concerned and would not administer CPR on him. But when the patient is on an ambulance, the Fire Services Department so far has yet to follow the guideline on the form. Deputy Chairman says he wants to ask Lee Chi-yong and another deputation to speak. Okay, Dr. Ho first. Just then I heard about the differences between ambulance and HA. So it exactly shows that a government-led policy is so important. And also, in the coming months, years, there'll be two hospitals collaborating, or essential homes collaborating with hospitals to provide palliative care. That's encouraging. And as for additional resources to be plowed into the sector, I think apart from monetary terms, I think we need to pay attention to the quality of services. What sort of quality is elderly people getting? Has their quality of life been improved? So we do need to have a mechanism to measure the quality of services. Let me remind you that because we have simultaneous interpretation, please, when you speak, please try to speak either in Chinese or English to make the interpretation easier or possible. And next one, Mr. Lee, I've got several questions for the administration. Because, say, if when we have arranged for funeral provisions, arrangements, or places in the columbarium for our children before our children die, then our directions or our thinking, will they be followed up on by the relevant department when we die? Or once we've passed away, and will the government departments try to find or consult our family members in the case our own children die? And say if our children become orphans, after they're cremated, will their actually ashes be paid tributes to? Do you want the administration to respond? I think the views are very clear. Firstly, the HA and Fire Services Department needs to, try to narrow the gap, and that poses difficulty to families and the patients. Whether of course, for patients and families who do not want to receive CPR, but on their way from hospital or from home to hospital, the wish may not be respected. So the HA, no matter how good your guidelines are, or how good a pilot scheme is, the whole idea may be overturned because the Fire Service Department says that it's not obliged to follow your guideline. So what sort of policy are we talking about? So is it that there's no way to change it? We need to deal with this gap. And also, as for mentally handicapped patients, before their parents die, they may have some wishes for their children in relation to their future death, but there isn't any legislation in place that can ensure that the parents' wishes will be followed up on. Even and when it comes to the arrangement for funerals or cremation for their children, and we don't know. There are a lot of unanswered questions. Can you think about that for us? I really doubt that you may not be able to give us the answers. I don't think you have the answers. But these are practical issues that we face every day. I don't think you'll turn a blind eye to it, but what plan do you have, Ms. Lee? Well, like to thank the deputations, we understand that we tended to focus more on elderly people in the last moments of their life. But I do agree that there are different groups who also are facing the possibility of death, and we'll try to incorporate the other concerns. But under the current mechanism, if there are children or disabled people who cannot make decisions for themselves, there is a mechanism, a guardianship mechanism, under which family members or the carers can make decisions for them. But for hospice care, we will see how we can incorporate that into the current mechanism. The guardianship order or the guardianship rights, the 8 rights concerned, as far as I know, actually do not cover arrangements for funerals. Well, they only cover medical decisions or financial arrangements, locations of where they live. All this can be implemented through the guardianship order. But for death-related matters, I don't think they're covered. So, Ms. Lee, you need to carefully check. Yes, we will see whether we can expand the order to cover death-related matters, or we can make separate arrangements. That's why it's something that we can look into. But I don't know. I know at this moment we don't have a concrete plan yet, but I agree that we need to consider extending it. But if we are to reform guardianship orders or guardianship rights, then is it under the authority of FHD or Labour and Welfare Bureau? Okay, let me make it clear. we will look at the whole issue in its entirety. We're not proposing that we should reform the guardianship order. We need to understand the crux of the matter first and to look at the needs of various groups and see what is the way forward. The best way forward. I think it seems like the administration has no idea at this moment. They may not have thought much about the matter. They may have neglected the issue all along. So I hope that you'll be reminded now. Just then Ms. Lee said that they will carry out some internal study. But in fact, we've got with us today all the experts, people who have done pilot schemes and similar services for many years. We've got academics here, doctors here, and so forth. So I don't know what sort of study you need to do. But today, we've heard from deputations, and I think what they've said give us a very good basis already. Please don't drag your feet anymore. There are 40,000 odd deaths every year. For a rich society like Hong Kong, if most people can't die well, then I think that's not something glorious to say.
Mr. Peter Cheung, thank you, Chairman. I'd like to thank you, FANG, more than 10 reputations and individuals for coming to speak with us on hospice care, the arrangements, the services, and the policy. Obviously, the government has got no policy. Otherwise, there will not be the contradiction between the HA and the Security Bureau. Ms. Lee has told us that they are trying to come together to talk about this. Well, I don't know whether with it would achieve something after change of personnel on the various organizations for a few times. We need to get a direction in the short term. And then with the change of personnel will not result in a loss of direction. And hospice care is not something just for the hospitals. It can be done by NGOs, and residential homes should play an important part. And it should also be done in the elderly's own homes and in the community. There's a point about saving healthcare resources, but I don't think that the policy should be judged in that light. If you want to save money, you might as well leave everything to hospitals. This is not an issue about saving medical or healthcare resources. I hope when people talk about hospice care, don't look at it from a resource-saving perspective. Maybe at the end of the day, you do save some resources, but this should not be the perspective to adopt at the very outset. The Labor and Welfare Bureau mentioned that another 5 contract homes will get more resources, but by how much? Maybe the SWD should tell us later. Obviously, the government is aware that if residential homes be asked to provide hospice care, more resources should be provided. Some NGOs are providing this in their own homes without additional resources. And they are doing this by using donations, for example. So I'm saying that you cannot ask the additional services be provided within the confines of existing provision of services. Don't think about that. And if you want to extend the service, you should model the arrangement on what you have provided for the 5 new contract homes. Whether the provision is sufficient or not is another matter, but at least you must provide something more. It's been said that 40,000 people die each year with 360 hospice care beds. Dr. Dai also tells us that the terminally ill or those who are chronically ill would need these most. Chairman, you said that 360 beds vis-à-vis 40,000 people is not adequate. But if the death is a result of an accident, sudden accident, then it's not really applicable. I have to ask how many people pass away through the terminal illnesses, and then I can judge whether 360 is a sufficient number. I have another question for the Food and Health Bureau. Ms. Lee, you have told us that the study has just begun, but of course, after the study, you may decide to do it or not to do it. It's still a long time before you come to that stage. When have you begun to talk about it? When have you asked the relevant parties? Did it start last year or the year before last? We want to get a sense of the speed with which the government is moving. Second, I want to ask the hospital authority a question. Will you provide more resources in the future on hospice care services? You briefly mentioned this, but it's not very clear. Is the direction to go one that would involve providing more resources? And also for Labor and Welfare Bureau, don't talk about the 5 contract homes. I want to know more about what would happen beyond the 5 new contract homes. Ms. Lee? The initial study has started with specialist doctors in the HA. And of course, there are internal procedures before we embark on a study. The study itself will need a year or so. But when we devote resources and manpower to carry out study, of course, we intend on doing something. It's not there just to show people that we have tried to do something. When can it be completed? Well, that depends on the scope of the study, but we estimate that the time required for the study itself is a year or so. Hospital authority increasing resources. Let me clarify a concept here. The number of palliative beds. It's not linked with the terminally ill. And that is to say, not every terminally ill patient requires a palliative bed. We have specialists, doctors, and nurses on palliative care to take care of a needy patient in other wards. For example, if someone is suffering from a renal failure, and if the doctor, the palliative specialist, thinks that he needs palliative care, and then the doctor or his team will go to the ward, and some other arrangements may also be made, such as home visits. This is an interdisciplinary collaboration. Those who are terminally ill, especially those who are suffering from chronic diseases such as renal failure, heart failure, they will need this more. And of course, they are also cared for by the relevant specialty specialists, doctors and nurses. For those who require hospitalization and medical care, they may be admitted to the palliative ward. So I would like to clarify this point. Please do not regard the number of beds as something very important. We have 40,000 deaths. If you want to take care of half of them, it's not possible, and it's not the international practice. So what do you think? Do you think the existing number of beds sufficient? It's not for me to say. Actually, the specialists concerned have been discussing this. I would say that the number is not low. What about international practice? Do they have 90% of our deaths happening in hospitals? I have to check. I will take a look. I can provide figures to members later. Mr. Peter Cheung asked about increasing resources. What do you say? We know that we are not doing a very comprehensive job. So we do have the intention to secure more resources so that we can provide more extensive services. Labor and Welfare Bureau. Thank you, Chairman. Thank you, Mr. Cheung. Mr. Cheung has mentioned that we need new resources to provide hospice care services. We understand that. We are not saying that we would be asking the 5 new contract homes to do it within existing resources. So we provide more resources. Are we going to continue to increase resources in the future? Well, these 5 new homes are yet to be commissioned. We'll take a look at how things go, how they are operated, and whether the elderly people are benefited from such hospice care services. And if we do see that, I believe that will be the direction to go for us. Of course, there's another issue of resource allocation, but we'll strive to get more. Of course, it's important to increase in resources. It takes resources to do things, but it doesn't mean that if we pay the money, it will be okay. There are other things we need to pay attention to. I'll ask my colleague, Ms. Lee, to supplement. Well, you are a chairman, and the members, you are all experts. I have visited some hospice care center. I have sat down and listened to what they talk. Hospice care is not that simple. In a residential home, the worker said that at the very beginning, not everyone would accept the hospice care program. It's important to change the arrangement, the mindset of people. And not all family members accept this. It's important to have everyone working together. And even if we provide resources to all the sub-rented homes, they may not be able to do a good job. They may not be able to do it. So there's some measures that we need to get in place. Manpower, hardware, the system, and other things all have to be in place. And that's why initially we'd like to start with new contract homes, which would get a fresh start. There's no past practice. And then when the very outset, the workers, the residents, and their family members all know that the hospice care will be provided in the new home. We have a deputation who has just arrived. I would like to give the representative 3 minutes. And then there are 2 more deputations who would like to speak again. All right, let's manage time well. I will give the time to Ms. Zhang Fan-Nan from DAB. Good morning, Chairman and members. Sorry, I was held up this morning by some other business. Hospice care is not just about the moment the person passes away. The scope of service can be very extensive, covering family members, carers, and workers. We would like to see that when the patient is about to pass away and before and after the death, services can be provided. The objective is to assist those who are terminally ill, and then at the very end of their life, when he faces death, he will not feel isolated and afraid, and he can peacefully pass away in a dignified way. And also, we would like to safeguard the quality of life at that terminal age. very often when medicines are no longer effective, and then we should try to deal with the emotional and physical needs of the patient in other ways. We have heard that HA is providing some service in more than 10 hospitals that it operates. One of my family members, a cousin, has just passed away. But the hospital that did not remind or ask the family members whether hospice care would be needed. So maybe this is not comprehensively laid out, and so more resources should be provided. We have heard from the officials that it may not be effective just to provide the resources to all. But as in other arrangements, you must get some achievement before people would accept the new arrangement or the new services. And some people would like to return to their homes when they are about to die. So home service, such as domestic services, should be provided. The family members may have to spend time with the patients, and chores have to be taken care of by other people. Of course, we hope more resources can be provided, but before that is possible, we would like to ask if the CCF, Community Care Fund, can offer help in the interim. Dr. Chow and Mr. Lee Chi-yong and Mr. LEE Siu-po would like to say 1 minute. Dr. Chow?
I've done some literature review, and I found that people who die in hospitals worldwide make up about 50 to 60%. About a quarter of the people pass away in a residential home. So I think that's a trend. And also in Bradbury, I'm on the committee of the Bradbury Care Center. At Bradbury, in every 2 weeks, they would actually receive new referrals. So the waiting time is not long, but they would actually set the priorities according to the situation of the patient. So I think Bradbury helps meet the needs there. Next one, Mr. Lee Chi-yong. I just want to ask about the arrangements for funerals. Justin, you mentioned the guardianship order does not cover funeral services. How about a will with legal effect, in which I, for example, allocate the distribution of my inheritance? And can I include a clause saying that covering the arrangement for funeral services? I hope that in the future, the review will not just look at giving parents one choice only. Next one, Mr. LEE Siu-po. Personally, I'm involved in funeral businesses, and I've been in the field for 9 years. I used to work in a residential home for the elderly, and I helped with visits and hospice care. But no matter how much we've done, it seems like we could not promote the ideas among family members. I hope that the government can face the issue and try to actively promote the idea of giving elderly people a dignified life in the last moments of their life. Whether we can help people die well, I don't think people do die well now. We're not talking about places in columbarium, but whether we should get people to draw lots to get places. Why can't we just get people to queue up? Actually, people wait, can't get a place in the columbarium after 2-3 years. But if someone is so lucky as to have the lot drawn, then someone, who hasn't had to wait long, can get a place. So I think the government need to look at, this whole issue of funeral services and the sector. Okay, just then Mr. Lee talk about arrangements for funerals and the carrying out of the will of parents. So, Ms. Lee, could you respond briefly? Thank you, Chairman, and the deputations. As for places in columbarium, we will discuss with FEHD and see what we can do together. And as for the will with legal effects, I can't give you a definite legal opinion here, but I will actually explore more about the matter and see what legal issues we need to resolve. So I can't give you actually any concrete opinion now. Okay, next one, 3 minutes for our members each, Vice Chairman and then Chung Ka-chu. Firstly, I propose that our working group should write a letter to inquire about the, why there's the gap in services between the Fire Service Department and the Hospital Authority. We do need to try to let the administration know that community representatives and the panel is so concerned about the issue. And as for private hospitals, of course, there are guidelines and palliative care beds in public hospitals. How about private hospitals? Because their positioning is different. There may be some middle class or relatively rich families who prefer to send their patients there instead. So what sort of experiences have the private sector got? And besides residential homes for the elderly, we'll look at it more broadly. How about home care, hospice care? Since the Social Welfare Department now is trying to improve its home care services, and since it's trying to increase the number of places, home places by 1,000, I think for the additional 1,000 odd places, would you try to improve the services? Who will respond? As for private hospitals and home care services, I think it's either. Okay, Ms. Lee, could you respond? I think for arrangement for private hospitals is a matter between negotiations between discussions between doctors and the families. As I said, the guidelines we have apply only to HA. I don't think there is a uniform practice among private hospitals, but I think according to the codes of practice, private doctors are supposed to discuss the matter with the families. Mrs. Chen? Yes, as for our plan to improve home care services, because, as we said before, previously, LegCo members and the sector agreed that the new 1,000 odd places will be open to public tender. So we can't make any more changes to the arrangement now to avoid further delay to the implementation of the new services. For community care, I think there's still a lot more issues you need to consider when it comes to provision of services for the community. So we need to see how we can work together with the community and also the homes. Okay, the Deputy Chairman suggested that we write a letter to the
覺得咧，可能我哋要去信政
Security Bureau.
因為呢一個
Because we need to see that various bureaus work for the field, but then it's difficult for the one particular bureau to take the lead in hospice care policy. So if the Food and Health Welfare Bureau is willing to do a study, how about the matter of guardianship order? When it comes to changes to legislations, maybe the Food and Health Bureau cannot take the lead. Of course, a Labour and Welfare Bureau can look at provision of residential homes and support from the community, but whether Labour and Welfare Bureau is interested or has the will to get more resources, of course, it wants to get more resources, but whose ultimate responsibility is it? I think various bureaus may want the other bureau to take up the final responsibility. So even for life and death education or 5 services, that could actually have implications for security or education bureaus. So I think this is a matter that needs to be put forward to the Chief Secretary, because now it seems like the matter is handled by all departments. So should we actually raise the level of seriousness of the matter? So because this is such an important matter, every one of us will go through death. We can't just leave it there. Particularly for the mentally handicapped, they may need the support of other sorts of legislations. Would you agree that if it's okay, can we? So we can, in the name of the panel, write a letter instead. So in the name of the panel, so that the Chief Secretary, based on the views expressed by the deputations today, that the Chief Secretary can set up a committee to formulate a actually hospice care policy for Hong Kong. Of course, I agree. If you want to see if you want the Chief Secretary to pay attention to the need for a comprehensive hospice care policy or to create a platform to hear public views, of course, I totally agree with that. But, but I just don't know. I'm not sure even the letter is written. I'm just worried that in the end, the Chief Secretary's office will just give us a letter in return, and then the Security Bureau will not act at all. Okay, Chung Ka-chu, I totally agree with writing a letter to the Chief Secretary, but I can see that the Security Bureau, in relation to the ambulance matter, it's not just a matter of whether the Security Bureau is going to take up the matter. It's that the Bureau may be worried about the potential share of responsibility it may have, and also whether families would actually take the Bureau to task. It's not, we do have the form there, signed form already, but but if someone wants to take up, who should take up the final legal responsibility? That's the ultimate concern. So I think, of course, we can ask the Chief Secretary to urge the various bureaus to contribute, but after all, Mr. Lee Chi-yong suggested a legal matter. When a patient who is conscious and if he has signed actually a proxy or authorization letter before his death, that kind of will or letter has legal effect. But for someone who cannot even take care of himself and who cannot sign any document with legal effect, and in that case, can his family members to authorize somebody else to implement arrangements for the third party? I really don't have the answer. Ultimately, we may need to change the law. So it's something that has to be dealt with by the Chief Secretary. But I think Food and Health Bureau should not just say today that it's nothing to do with it, something unrelated to their work. I think it has the responsibility to clarify, to clarify the whole matter. It needs to give us an answer what its position is It's not that writing a letter can exempt them, the Bureau, from telling us what their responsibility is. It needs to, discuss with DOJ, and if it turns out that the idea of Mr. Lee works, then it needs to let us know. I think on the whole, this panel actually will consolidate all the questions raised today and compile them into a report. Hospice care policy is very important, and all your views will be put on record, and we'll ask the administration to respond to your views and concerns raised. Even though our panel will start meeting soon, but the issues will not go away. I think that's the end of our discussion. Because of time, we need to adjourn the meeting. Over the past half a year, 1 year and more, we'll actually move a motion based on the discussions in the past. We'll move a motion in LegCo, and we'll submit a report to LegCo, and we'll urge the administration to respond to the concerns raised in our report. So that's the end of our meeting today. Thank you. At the same time, let me remind you that the Secretariat will compile the report for us, hopefully by the end of July. We can call an internal meeting. Then we don't need the administration to attend. Your pain is over by now. It's come to an end. And outstanding work for us is, once the panel has approved the report, we'll just follow the procedures required. Thank you.